Welcome again. Today, the fifth session, the webinar, is talking about building sustainable delivery systems for blood transfusion services. And the points of discussion are on policy and regulation, new frontiers, and building a donation culture. So basically, we will have discussants and speaker talk about the improvement of safety levels for blood and blood products, quality of product and service, and yet keep the blood available where it is needed, when it is needed, and also appropriate use and accountability. So you're welcome. We'll start by welcoming our keynote speaker. Our guest was to be Dr. Patrick Amos, the Director General of the Ministry of Health. Unfortunately, he didn't manage to come, but he is represented by Dr. Ogato, who is the head of Directorate at the Ministry of Health Care Services. So welcome, Daktari. Then we have our next speaker, who is Dr. Susan Jogo, who works at African Resource Center and is supporting KNBTTS and also supports ministries on supply chain strengthening. So welcome very much, Dr. Susan. Then we have Mr. Alex Mutai, who is the head of registration of blood and blood products and works at the Pharmacy and Poisons Board. Then we have Mr. Welcome, Mr. Alex. Then we have Mr. Aaron Ogunde with Damu Sasa. Then we have Mr. Rocky Jumapili, the County Blood Coordinator, Kwale County. Thank you very much. So you're all welcome, and we have our very own Mr. Chepkok Kiprono, who is the County and Partnership Coordinator supporting KNBTTS on the county matters. So I gladly welcome all of you, and I know that you're going to have a very fruitful discussion. So we will start with Dr. Ogato, the head of Directorate. Karibu sana, welcome.
Thank you, Christine.
Yes, thank you.
As you've introduced me, my name is Dr. Ogato. I work in the Ministry of Health, and I'm the acting head of the Directorate of Healthcare Services, which is quite a broad directorate. And among the functions within the directorate is blood transfusion services. So without wasting time, I want to bring the apologies of our Director General because of competing interests. He was not able to make it today, and he has requested me to give his address, which I will quickly do. But then before I do so, I will make my own observations. Blood is a very important emergency medical product, unfortunately, that we don't manufacture or we can't buy. And it is always required as an emergency medical product, which is most of the time life-saving. Therefore, its availability when and where you need it is very important. And reliability in terms of getting it when you need it is equally very important. After having been in charge of various hospitals for many years, I've got personal experience on what it means to lack blood. Many times I have lost patients from preventable things because of lack of blood. And it is very disheartening and it is very hurting to the health workers and also the family members when you lose a person because of something preventable. So as a ministry, we have invested heavily in terms of making blood available. And I believe that all the colleagues present here today will attest to the fact that this calendar year, blood has been more available than the previous year. After having said that, allow me to read or present the remarks from the Director General. Colleagues in the profession, ladies and gentlemen, it gives me great pleasure to be your keynote speaker this afternoon on webinar session 5 on building sustainable delivery system for blood transfusion service. I wish to convey a warm welcome to all participants from the Ministry of Health, both the national and the county governments, the faith-based organizations, and the private sector. As you are aware, the World Health Assembly resolution on availability, safety and the quality of blood products, that is resolution 63.12, urges member states to take the necessary steps to ensure operation of regulatory authorities. Over the past years, the government of Kenya has developed constitutional, legal, and a policy framework for enhanced health care of her citizens and for the management of health products that are both manufactured and those derived from humans. This include 1, the Constitution of Kenya. Article 43 of the Constitution of Kenya 2010 on the Bill of Rights guarantees every Kenyan the right to the highest standards. This we know very clearly as health workers. Number 2, universal health coverage. The session of paper number 7 of 2012 on the health policy on universal health coverage in Kenya provides direction on the roadmap to achieve universal health coverage as aspired in Vision 2030. Number 3, the Kenya Data Protection Act. The Data Protection Act number 24 of 2019, Part 5, sets ground for the processing of sensitive information for personal data relating to health, conditions for transferring data out of Kenya. Ladies and gentlemen, the Ministry of Health, through the Department of Blood Transfusion Services, Tissue and the Human Organ Transplant Services, is responsible for meeting the blood and the blood products needs of patients by ensuring the availability of safe and equitable access through the establishment of effectively managed national blood supply and transfusion services. Colleagues, Kenya has experienced increased need for blood and blood products. And for us to meet this need, it is prudent to increase the number of blood collection establishments in the country. According to the data we have, 12 counties do not have any blood collection establishment. But I want to assure you that we are working with the counties to ensure that this is achieved. To ensure that there is equitable access of blood and blood products, the Ministry of Health is focusing on these key areas. Number 1, increase in blood collections to meet the needs of Kenyans as per World Health Organization guidance, which requires countries to collect units equivalent to 1% of the country's population. In Kenya, that translates to about 500,000 units per year. At this point, let me thank my fellow Kenyans for voluntarily donating 273,338 units of blood so far this year. This figure is the highest annual collection ever in Kenya since independence. And that is why I said earlier, I can say with confidence and without fear of contradiction that health workers can confirm that we have more available blood this year than any other year before. Number 2, development of national policy on donations, transfusion, and the transplant of human-derived medical products. Number 3, enactment of Kenya National Blood Transfusion and the Transplant Services Bill 2019 that integrates management of blood, tissue, and human organs to have all medical products of human origin under one management. Number 4, promoting the accountability of blood transfusion services through use of information communication technology. Currently, blood management information system is at advanced stage of development in collaboration with the Ministry of ICT. The blood management information system will support the vein-to-vein information management and the visibility of blood movement. Number 5, development of intergovernmental framework to ensure that the national and county governments collaborate to attain self-sufficiency in blood and blood products. It is with great pleasure to warmly welcome you to today's session on building sustainable delivery systems for blood transfusion services. Thank you. I submit. Christine?
Thank you very much, Dr. for that presentation. It is fully loaded. And I think the statement of the day will be, can't buy, can't manufacture. That's a very, very strong statement about blood. And we are also very humbled and privileged to have you with us. Thank you very much. So our next presenter will be Dr. Jogo. Welcome, Dr. Dr. Jogo.
Thank you, Christine. Sorry, I was trying to share and unmute myself. I hope the slides can be seen and I can be heard. The panelists, maybe one can respond.
Yes,
okay.
Yes, Dr. You can be heard. Thank you.
Okay, thank you very much. All the panelists, thank you, Dr. Ogato. Thank you, Dr. Nduku, who is also with us. My presentation will build on what Dr. Ogato has presented, because it's more on how do we build a sustainable delivery system for blood transfusion services. And from Dr. Ogato's presentation, you can see that something has actually happened for us to collect the highest number of blood units since independence. So we are on a roadmap or a pathway to, or progressing to our vision or our goals. So this is, my presentation is very short, and we have panelists who will actually also build into it. So it's more of to guide on the discussion on the way forward, because system is for all of us. So this is the outline, a brief introduction, talk about the policy and regulation, which is very important for blood and blood components. Asking ourselves, how do we build a donation culture? Because I think this has been the struggle. How we can make sure that we have people who culturally we have them, but we have not achieved the number that would sustain us. Then key priority areas for the future and the new frontiers. So when we talk about a sustainable blood system, what do we mean? So this is one that maintains or improves on current safety levels for blood and blood products. It provides blood for the full range of clinical applications consistent with the standard practices, and delivers blood in a timely fashion such that patients' health and preparedness are not unduly compromised. So this is the system that we are looking for, and being able to sustain it. So we know that for the system, For a sustainable blood system, it should maintain incentives for innovation. We are in an era where innovation is very critical. Operate efficiently in terms of production and delivery, minimize disruptions from routine market changes, and has sufficient surge capacity to cope with emergencies and other significant disruptions. So we know that for blood supply chain, or for any blood system, we have inputs, knowing that our key output is the blood and the blood products. And for the inputs, we have the health products like the blood bag, the reagents, the consumables, and the rest. And we have the non-health products that are very critical. You will not say that since I have blood bags, then I can go and collect blood. You need the sodas that after the donation, they energize them and motivate the donor. So they're very important. And we have to think about the supply chain for both, because they are different. Most of us coming from the healthcare area and our training being healthcare, most of the time we may be biased about the health products and forget about the sodas and also the logistics that go with it are very important. So this is just an overview of the supply chain. Any product, the supply chain that is required. One, we know that we have the product selection, which applies for both the inputs and the outputs. We have to know, like the blood bags that we have to use, the reagents that are to be used based on the platforms that are more efficient. When it comes to the blood and blood products, we have to know the products that will be processed. I think our first session was on appropriate use of blood and blood components, and we realized that we have a lot of the products that are available, but maybe we were not sensitized enough to know what is available and use them efficiently. So when it comes to even the blood and blood components, even the selection is very important. Quantification also applies to both the inputs and the outputs, because you have to know, for me to collect this number of units, how many bags do I require? How many sodas do I require? How many reagents do I require? And what is my target for them, for the blood collection and the components? And also planning for the same supply chain and supply planning, and that's what we call logistics. There's procurement or acquisition, and we know for the inputs and the outputs, again, the way we acquire them is different. For the inputs, we have to purchase like any other health product. For the blood and the blood components, we have to rely on donation. Very important. So you find that KNBTTS has a lot of work to think about the two supply chains, about the inputs and the outputs. The two supply chains are completely different, and the management has to think about it, plan, and make sure that products the blood is collected, it is processed, and it is at the right place at the right time. We have storage and distribution, and of course use at the hospitals. And we see that all these areas we have information management. How do you monitor the pipeline? We need financing, supervisions, and the M&E. So this applies to all any product that has to go through the supply chain, and we know that it has to be guided by policy. Every process has to have monitoring for quality, and of course we have to be cognizant of the adaptability, because there are a lot of changes that are coming, and we have to be very adaptable to them. So we are used to these, we know about them, the 6 pillars of the health system, very important. They also apply to the blood system. And more important is to look at what is on the right. What we want at the end of the day is customer value alignment. All this work we are doing is to make sure that the customer or our patients at the hospitals, they get value for all the investment. They get the product at the right time, and they actually also get the quality product. So we have to be strategic about them. When it comes to structure, we have to look at network optimizations and channel design. How best can we make sure that once we collect the blood, it is processed, it is stored, and it reaches where it should be, one, in a cost-efficient way. So looking at how do we even change the design, moving away from what maybe we have used before and it didn't work, to moving to what is more efficient. We have operations where we are looking at sourcing, production, and inventory management, looking at the transportation and what facilities we use, and also having integrated planning where we bring in even other partners. We have the faith-based, we have the private sector, and making sure that event regulation apply to all of us. And then there is the foundational pillar where we have technology, we have the people, processes, and performance measurement, knowing that what is not measured is as good as not done. So very important to look at this, and moving forward, looking at how do we improve each and every area of these pillars. So when it comes to the policy and regulation, I'll give an overview of the WHO strategic framework for blood safety and availability, that is 2016 to 2025, and also give an overview of our policy that is still a draft. And we are hoping that very soon it will be endorsed and gazetted. So first look at the WHO targets and look at, for us at a country where we are. So you'll actually find that for all these, we've started something and it is in progress. So development or review and implement a national blood policy and strategic plan for the national coordinated blood transfusion service. The policy, we have a draft policy, and for strategic plan, it is in the planning. We have development and implement an appropriate framework for regulatory mechanism for the registration, licensing, operation, and inspection of blood transfusion services. Again, we have standards that are being developed on this, but it doesn't mean that there's a vacuum. You already have a guideline that PPB uses for licensing and registration of establishments. And I believe Mr. Alex from PPB will also be highlighting on that in his remarks. Achieve 100% voluntary and remunerated donations from low-risk populations. Again, we know this is what we do. We are not where we should be, but I believe the most important thing is voluntary and non-remunerated. The key thing is how do we encourage the donors to continue with the donation. Achieve or maintain 100% quality assurance testing of donated blood for TTIs. Again, this is, for quality system, it is a continuous process, but all the groundwork is done. We have the standards, we have the SOPs, and the healthcare workers, they are well sensitized on the quality system. Process at least 75% of the whole blood collected into components within a quality system. I think even for KNBTS, our target is 80%. So we can see that we are in progress. We may not have reached there, but it's something that, again, the service is working hard to make sure that it is achieved. Develop and implemented national guideline on clinical use of blood. Again, that is in place. I think it was just revised, and I believe sensitization of the healthcare workers will be done very soon. Establish functioning and sustainable hospital transfusion committees in at least 80% of the hospitals. Again, this is something that is on the table of Dr. Nduku. Just looking at which hospitals are doing the transfusions and the ones that have the transfusion committees, because the committees are the ones that promote appropriate use, the quality and safety in the hospitals. Implement national quality management systems at all levels of the blood service. Yeah, I say that this one is in place, and being a continuous process, we have to continue improving, and establishment of a national hemovigilance system. And what we realize is that when PPB, they have a pharmacovigilance, they had a pharmacovigilance guidelines, which was revised, and it was called a vigilance guideline, and it introduced hemovigilance. But what KNBTS is doing is also to make sure that for the reporting tools, the data collection tools are available, and the healthcare workers are well sensitized to have the system up and running and provide data on the safety, because this mainly provides safety on the patient and also the donors, because some of them may have adverse events. So the strategic framework continues to give key intervention components, and these are some of the things that have actually helped KNBTS for within 1 year to ensure that they collect blood units that have never been collected since independence. One is a strong leadership and governance system at KNBTS, support and coordination and collaboration, a lot of collaborations with the national collaborating and coordinating with the county and also other stakeholders at the faith-based and the private sector. Then strengthening provision of safe blood and blood products to meet patient needs, promote appropriate clinical use of them, blood and blood products. And you actually find that our first session was actually on appropriate use of blood. So, and it was well attended, and many people were able to get even case studies of where we are doing well and where we are not doing very well. Strengthen quality system management through the blood transfusion chain. Again, as I said, this is something that is happening. Standards have been developed, and documentation is encouraged, and reporting is also done on monthly basis, just to know what we are doing and where we should improve. So for Kenya, we have a draft policy framework, and the first objective is on regulation and legislation. We have the second objective, that is to ensure safety of donors and recipients of medical products of human origin. We have the third objective, to ensure safety and efficacy of donation, transfusion, and transplantation. So you realize that this is not only on blood, it has expanded to also the transplantation. We have objective 4, to promote and educate a naturalistic and humanistic approach that enhances availability of blood cells, tissue, and organs. Objective 5, to provide a finance framework for donation, transfusion, and transplantation services for all Kenyans. Very important, because this is one of the pillars of the health system. And again, without finances, we may not be able to do a lot. Objective 6, establish a framework for an efficient and stable supply chain system that ensures security for laboratory and medical commodities. So basically, these are the inputs, and we said without inputs, we'll not be able to actually even start the donation process. So very important. Objective 7, to establish and build capacity of human resource for blood, cell tissues, and organ transport, regulation, management, and service delivery. Through these webinars, this is happening, and it doesn't stop here. There'll still be other avenues for more capacity building. Objective 8, to define and clarify the role of and linkages of the national and county government, private sector, and faith-based organizations. Very important, because we find that partnership and collaborations are very important in this system to make sure that a patient, regardless of where they are served, whatever they receive is quality and safe blood and blood components. Objective 9, we have contribute and apply scientific evidence from surveillance, monitoring, and evaluation and research. And I believe this is one of the parts that maybe we've not done very well, especially on research, where we need to even understand our population, their characteristics, and be able to say that this is we have mapped out and profiled our donors and also our patients, and it being here in the policy is something that will actually be done. Then objective 10 is to transform Kenya into a center of excellence in blood, cell, tissue, and organ service. So you can see that the policy has encompassed all the areas that are required to have a sustainable blood system, and we hope as it gets gazetted, we'll be able to achieve all these objectives. So how do we build a donation culture? We have had the conventional approaches where we should understand our donors, identify target blood donor populations, have communication framework for donor education and community involvement, build partnership with the media, mobilize community partners, and create networks, maximize the impact of World Blood Day and also other national events. And all these approaches have been used by the service. But moving forward, we are asking ourselves, what else can we be able to do? Can we be able to go to areas that have high human traffic, like Huduma centers, the malls, and just have a static collection point where those who don't feel comfortable going to the hospitals or going to the blood centers or going to the drives, they are too busy, but maybe on a Sunday after church or they're in a Huduma center, they can be able to just go as they're being served, they also donate blood. So these are the things that the service is exploring to see for the future. How can we first make sure that even the process is cost effective And we take services where the people are, and somebody knows I don't have to wait for a drive, but I can just go and donate blood in a particular place. Then again, how do we demystify the myths that are within our cultures? I cannot donate blood to be given to somebody I don't know. I can only donate blood to my relative. So how do we demystify that? Then creating a sense of belonging. We are in the era of social media, where you find that people are in a WhatsApp group, they're in a Facebook, they're in a group. Is this something that we can explore moving forward, so that also people feel that by giving their blood, they also giving to the society? So these are ideas that we're exploring, and I believe we'll be able to discuss more with the panelists here. So here we ask our question of what does Kenya need? We look at the national blood supply objectives of adequacy, safety, quality of blood, of the product and service, appropriate use, accessibility and accountability, and how this can be anchored to the UHC. And the pillars, we have the policy framework, sustained regular blood donations, operational county support ecosystem, very important, because you find that for the blood system, we have what the national can do and level can do and what the county can do. And the end recipient is actually at the county, apart from the national hospitals or referral hospitals. How can we have a nationwide blood banking and equitable supply and distribution system? Whatever a patient in Nairobi is getting, even the one in Mandera or in Turkana will also get. Functional regulatory environment, national blood and blood product security mechanism, making sure that whatever we give is secure. We don't have our blood maybe leaking out and such. And also the security that somebody doesn't use the blood we've collected for research, and people understand what our community is like, and use that as a biological weapon. Structures to operationalize change. We have the BMIS, the Blood Management Information System. We have a session, the last session on Friday, and we'll be able to get more details about the BMIS, what we are expecting, what it will be, and what it will solve. We have the TWGs that are in place, like the M&D and the surveillance will be looking much into the research. Also improved stewardship. How do we work with the faith-based? How do we work with the public sector? How do we work with the private sector to ensure that one, there is engagement, and also there is regulation such that whatever unit goes to a patient, all the standards have been adhered to. So this is just giving an inter-county framework. What we know is that for the Transition Authority Legal Notice number 182, the blood transfusion service is not transferred to county health facilities that undertake the treatment of the transfusion. We know that they are at the county, so very important to have an inter-county, intergovernmental framework. And I know Jumapili will be talking much into that, and also our coordinator, county coordinator, Mr. Chepkok. So you look at donation, it is a shared function because we have also the counties, the private sector, the national government doing donation drives. When it comes to specimen referral, it is a national function. We have processing and banking, which again is a shared function. We have testing, which is a national function mainly done at the 6 RBTCs. We have reallocation and transportation, it's done by the national, and the transfusion, the service itself happens at the county, save for the national referral hospitals. So you can see that there are a lot of shared functions, and the ones that are specific to the national government and the ones that are specific to the county government. So having a framework, this is something that is being thought through, and just to ensure that we have such a framework to ensure that the national government and the county work very well, and also bringing in the other partners, the faith-based and the private sector. So key priorities into the future, we have in the immediate gazettement of the policy standards and regulations, emergency preparedness of the national supply chain was very important. We've seen disruptions before, and it's something that we don't want to to get us unaware, and then having an enhanced transparency through the centralized BMIS, being able to know which blood and blood components we have. For supply chain, we have all the inputs. For hemovigilance, I'll not preempt what we expect on Friday, but basically the BMIS will bring data visibility, both to the national level, county level, and all the stakeholders who are involved. So we have long-term plans, that is to have 1 million units by 2024. As Dr. Ogato mentioned, WHO guides that countries should be able to collect at least 1% of the blood units of the total population. Having sustainable donor pools, 3-year pipeline security for inputs, because planning is very important. You're able to know where you have deficits or gaps and plan for that, and do resource mobilization. Manufacturing of products, very important. For reagents, you know that they are 100% imported, and even manufacturing things like plasma derivatives, something that as a country we need to think about. Then regional blood reference laboratory, very important, so that again, that's where most of the research will be done, and also act as a quality assurance overall for the country and the region. So what are the new frontiers? We are in an era of internet, a lot of innovations and all that. And for the Internet of Things, where you are having advanced technology that facilitates applications, devices, and objects to communicate among themselves through the connected networks. We find that if Internet of Things is to be used it has been used in the healthcare to facilitate tracking, identification, and authentication, automatic data collection and sensing, where by maybe just having a chip or a radio frequency identifier, you just need to scan it and it gives you the information from where the blood unit was collected, into what components it was made, where it is going. So you can be able to have real data on a particular blood unit. We have seen drones being used and other vessels for agile on-demand delivery services. And thank you to Dr. Nduku and Dr. Ogato to make sure that every county has a satellite or a center. But you realize that some counties are very vast, and you have to think about, for that remote area or distant facility where donation may be required, how does it reach there within a very short time? Then also looking at adaptive inventory models for the supply chain that could lead to could be responsive towards the demand fluctuation. And the last one is research. Very important that we bring our academia, our research institutions work together to ensure that for this area that we've not researched a lot, we are able to understand and do research with what we have and improve, because research helps us to improve on our practices. So thank you very much. And back to the moderator, Christine.
Thank you, Dr. Susan, for that elaborate presentation. You have really given us something, building a donation culture and also what Kenya needs. That was great. So now we are moving to our second session, where we will have the discussants now give us, put some input on what the two speakers have put across, especially give your own experiences and what you have seen. And our first discussant will be Mr. Alex Mutai, the head of registration of blood and blood products. Welcome, Mr. Mutai.
Thank you, Christine. Good afternoon, everyone.
Good afternoon.
It gives me great pleasure to be here today and share together in this forum. First and foremost, I want to thank Dr. Ogato, who has really highlighted the critical and pertinent issues that are within us to enable us to have a sustainable delivery system for blood and for blood transfusion. And Dr. Njogo, our just immediate speaker, who has highlighted on the developments and what they're looking to achieve within the blood service system to enable that we have a sustainable again delivery system for blood and blood components within the system. I think for me, mine would be more to deal with the regulatory system for blood and blood products. And as highlighted by the previous presenters, it gives me great pleasure also to highlight that currently there is synergy within the blood service and the regulatory authority on issues and matters blood and blood components. As we are all aware, the dry products, which are purely pharmaceutical, which are the blood products, plasma-derived medicinal products, are already being regulated and registered through the Pharmacy and Poisons Board, which actually come from the same base, which is the donor. Ours as a regulatory body would be to ensure that we have a system that will be able to respond and to provide for safe and quality blood products. There are so many benefits of regulation. One is to strengthen the blood regulatory system. Another one is to ensure quality, safety, efficacy, which is a critical point within the universal health care and the sustainable development goals. 3 is to provide synergy between service and regulation and other stakeholders. And 4 is to ensure accessibility, a key factor, accessibility. You could have the products, but then the accessibility, just like you violated, is you're looking at a system where you're going to provide more services down below than up, because that is where the need is. I want to put it across also that we have done a lot together with the blood service, especially in this forum. We have been doing activities like hemovigilance activities. We had a support from WHO. We carried out with some members from the blood service, some pilot assessment for good manufacturing processes within 36 facilities in the country. And today we are able to really have a glimpse of what is happening within the chain. My point of view would be we need actually to continue to strengthen the system, strengthening the system. Because if we can only manage to strengthen the system, then we can be assured of the product that is reaching the clients down below or wherever they are, in whichever part of the country. Key point to this is safety. As you are aware, if we are not going to provide that assurance of safety, we will have an issue, transmission of diseases, substandard products, and so many others which really will bring a lot of issues within the transfusion chain. We have managed to develop guidelines as a regulatory body for registration of blood and blood products, and also the licensing for blood establishment. We have also managed to develop guidelines on complacent, plasma, where the current situation due to COVID and any other event, we have a guideline that you could easily adopt and adapt and provide for with whatever the situation arises, to be able to do CPs within the country. The other thing that we've been able to do is to integrate the hemovigilance activity within the vigilance system. And also, we have not just reached there, we have also done device vigilance, like blood bags. We went around the 36 facilities, and at times you could find a blood bag that is in the system that has no name, and it is still there. The anticoagulant is not enough, and so many other issues within the system. And I'm glad to report that we will intensify this so that at least wherever we have the blood containers, the blood bags that are coming by are regulated and are monitored within the transfusion chain. With the reviewed and the revised CAP 244, I think what we will need to do is to roll out.
Alex, kindly,
Yeah.
kindly, you have another 3 minutes, kindly.
Okay, I'm finishing actually. We will look upon doing other activities together, like doing GMP inspection so that we can be able to license the facilities. And also we will be able to intensify trainings, and we'll be able also to go around looking around at what else can be done. What we need is resources, what we need is personnel, what we need is policies that we will continue to develop so that at least we can even respond to the expanded program for the Kenya National Blood Transfusion and Tissue Transplant, so that we can include tissues and organs. I think with that, with any questions that we will come by, we as PPB, we are ready to support the system to deliver, and we'll be able to actively work together with the blood service so that we can achieve the goal that we so desire, that we'll have safe and quality blood within the transfusion chain. Thank you very much, Christine. Over to you.
Thank you very much, Alex. You have really tried to keep up with that time. Thank you for even the presentation that you have made. Our next discussant is Rocky Jumapili. Kindly, you have 10 minutes. Give us your views on what has been put across and your experiences. Thank you. Jumapili, kindly come close to the mic. Come close to the mic. We can't hear you very well. Jumapili, hello? Okay, as Jumapili sets himself, we could have Chepkok as our next presenter. Kindly go ahead as we wait for Jumapili to come back.
Good afternoon, all.
Good afternoon.
I hope I'm audible enough. I think mine I'll be discussing mostly on partnership. And why I'm talking about partnership is that for us to have a sustainable delivery system, we need to build a lot of partners in ensuring that at any given time we have blood, and not only blood which is safe, accessible to any patient who requires. I'll start from the side of donor recruitment, and for us to ensure that we have enough blood, we need to do the so-called recruitment of donors. And recruitment of donors is one aspect, and retaining these donors. I can bring into the context that in Kenya we require around between 500,000 to 1 million pints of blood each year. We have a population of 50 million. Out of the 50 million, the people between the ages of 16 to 65 is more than 30 million. If everybody can donate 1 pint per year, you can see we have more than 30 million pints. But why are we not getting this? It's because of one thing, the donor recruitment. And I can talk right now that KNBTTS right now is widening its wings, and they're working with the counties in issues of recruiting and retaining of donors. This will ensure that we do more of donor education. And the other thing again is, how do we ensure that our donors trust what we are doing? And that is why KNBTTS is coming up with a blood management information system, which will be able to monitor blood from vein to vein. When I talk from vein to vein, it means that from the time you are collecting to the time the patient is able to consume the blood, and there will be a message going back telling the patient that thank you, your blood has been used. The other thing under that one is how have we structured our blood donation centers? Is it something which is attractive to our patients? Have we located our blood transfusion next to the mortuary, or next to our casualty, whereby whenever a donor the other issue is our turnaround time. As we speak right now, our target is around 48 hours. But before the end of the year, we want our target to be around 24 hours, so that by the time the blood is being donated and the time we are screening and blood is available in our banks is within 24 hours. And KNBTTS, they have really brought in a lot of reforms, including using the couriers to transport the blood. And I think in future, where we should be going is the use of drones and other applicable issues. The other thing is, yes, we can get blood. We can mobilize donors, but do we have the storage capacity? And right now we are going to the counties. I'll take, for example, a county like Moya, that is Marsabit. From the headquarters to the farthest hospital is more than 400 kilometers away. Whenever they need blood, an ambulance will get from the headquarters, an ambulance will come from the other side. Where they'll meet, that is where they'll do the transplant. That is why we have talked about how can we that this blood can be delivered at the shortest time and it is being used. And when we talk about consuming of blood, and I think this was covered in the last webinar, where we always talk about use of products, the appropriate use of blood and the blood products. Do we transfuse whole blood when we just require platelets? Do we transfuse whole blood when we just need the fresh frozen plasma? These are some of the systems we need to build. And all these should be anchored through the so-called the policy and the regulation. And it is good that last week, 2 weeks ago, the policy on blood and blood products was approved. And right now we can see that we have a policy to be used immediately. The cabinet secretary approves it, but it has gone through all the other stages, and we can see that we are almost having a policy on that. The partnership with the counties, we have an intergovernmental framework, which right now we can really work comfortably with the counties. And I liked one of the questions which was saying that how can we make our people, or how do we bring in other players so that we can work? As we talk right now, we are working with the youth, we are working with everybody to ensure that enough blood is being produced, is being collected in the country. So I don't want to add so much because Dr. Gato and Dr. Nyoro have really covered most of the things. Let me stop there to give other people a chance. Thank you. Up back to Christine.
Thank you very much, Mr. Chepkok. That was great. Let's get to hear whether Mr. Jumapili Rocky, are you back with us? Rocky Jumapili? Okay. It seems we've lost Rocky. Let's see whether he'll be back by the time. Aaron, we can have Aaron to present for us. Damu Sasa, Aaron.
Thank you very much, Christine. Can you hear me?
I can hear you. Just go ahead. Thank you.
Let me start by saying thank you for this opportunity, and to also thank the speakers who have come ahead of me and all the wonderful things that they have said and then noted. Mine is to add just but a few to the many great things that have been said. And this is based on my experience working at Damusasa for the past couple of years. And Damusasa has been working to facilitate the sharing of life, through blood donation. So in terms of, what the keynote speaker said in terms of new frontiers, and which other speakers have alluded to as well, especially in terms of leveraging the data that is collected. In terms of leveraging the data that is collected, we could look at the blood donation patterns. And in our experience at Damusasa, one of the things we've noticed is that most of the people who donate blood for the first time are usually aged between 16 to around 28 years. But then the challenge becomes, where do all these people go? Because the people who are most likely to donate more than once, from the information we have also as Damusasa, are married females aged 28 to around 35 years old. So it actually points to the fact that one, people who donate for the first time and likely never donate again are the youth. And then the people who donate more frequently are, the population that seems to be married. So that's something to look into. And as one of the speakers before me said, that we need to look at key population groups that we can target. Those are some of the key population groups that we can target, and especially now looking at the fact that these efforts will be advised by data. Also, it would be important to look at the blood demand patterns across the country, like which is the one ailment or condition that is consuming the most blood. So is it mother and child? Is it oncology? And if we were to look at this information and say probably mother and child is consuming the most blood, how or what can be done, especially maybe in the prenatal clinics, to ensure that we try and potentially reduce the demand that will be on the blood that would likely be demanded by the mothers who are delivering. Also, in terms of looking at the screening data that is collected, I think that the KNBTTS and the Ministry of Health are at a very good position to actually advise the country on disease patterns even. So for example, they would be in a much better position to advise maybe on the prevalence of malaria in certain counties and the like. In terms of policy and regulation, one of the things that has become apparent to us, and which we feel would have quite significant impact, is that it should be optional, where donors have the option of meeting the patients who end up as the recipients of the blood that they've donated, and the recipients also have the option of meeting, either agreeing or not agreeing to meet the donors who've donated the blood that has ended up saving their lives. So one of the speakers before me also mentioned the fact that when you donate blood and you get a message and it says your blood has been used, it goes a long way, especially in helping to create and to demonstrate the impact towards building a more sustainable blood delivery system. In terms of building on a donation culture, one of the things that we really need to look at is how we interact with the blood donors. So the first thing that we in Damusasa believe needs to be done is the matter of convenience. For example, a donor should not move from one corner of town to the other corner just so that they can donate blood. It should now be possible for donors to locate blood donation centers, which are closely available to where they either live or work, so that it's very easy for them to actually just do a walk-in and donate. And I saw one of the points is that the KNBTTS is working on building static points, across areas, various areas in different counties. Then also the other point on building a sustainable or donation culture is customer care. So I'll give an example where if I walked into a bank right now and I was going to say maybe deposit 10 million shillings, there's a level of customer care that I will be handled with, which makes me feel proud of myself, which makes me feel like I want to come again and again. So I do believe that this is the same kind of care that should be given to donors who walk in blood donation centers. And this is primarily because this is somebody who's coming to donate, and this is somebody who's coming to, save lives through that simple act of donation. And as we're aware, one donation can save up to 3-4 lives potentially. So the person who takes their time to voluntarily come and donate blood should be treated with that kind of care that somebody would get even at another corporate office, for example, a bank, like I've mentioned. Also, the third point in building a sustainable donation culture is donor appreciation. So working in Turkana, Damusasa, we once learned that simply saying thank you to someone who is coming to donate goes a long way in entrenching the need for regular blood donation. That thank you, it's 2 words, but very, very important to a blood donor. Then the fourth point in building a sustainable blood donation culture is after sales services. So the same way when you buy your sofa set, when you buy your microwave, when you buy anything that you buy, there's that after sales service where the manufacturer or the supplier will reach out to find out how the product that you've purchased is working for you. The same case should be applied even in the blood donation space, where the blood donation center has an outreach program where they reach out to donors that have come through to find out how the donors are faring on. And this is especially useful, especially if we want to also have a mechanism of making sure that we get to learn from the donors, if at all they are experiencing any form of discomfort, which could be a blood donation reaction. And this actually helps for them to actually report. And this brings me to my fifth point, which is enabling the donors to have the power to offer feedback to the blood donation centers, where if I walk into the blood donation center and I find something that is good, is being done well, I have the opportunity to give feedback and say that should be maintained. If I find something that is not right, I should also be given the opportunity to give feedback and say this needs to be improved. Last but not least is to also look at transparency in the blood donation service. So one speaker before me mentioned that it's good when a donor gets that message that says your blood has been used. For me, that is a form of transparency, where going away knowing that I have actually left my home, I've gone to the blood donation center, and my blood has ended up being used, and that means it has ended up saving a life, goes a long way in making me to make myself available the next time I am called in for donation. Then, of course, one of the speakers talked about partnerships, which are very important, especially in working together, with the counties, with the private sector, to make sure that blood donors are encouraged to go and donate towards building a safe and regular blood donation culture. In closing, blood donors and patients are some of the most important stakeholders in the blood services value chain. Accordingly, everything we do, whether in government or private sector, is to the primary benefit of these two stakeholders. Therefore, going forward, and in order to facilitate the sharing of life, everything we undertake as an ecosystem must be both patient-centered and also blood donor-focused. For a very long time, we have built surveillance metrics, systems, processes to ensure that patients get safe blood and blood products for transfusion. It's now time that we also focus on building the exact same metric systems and processes to ensure that we maintain effective engagements with the blood donors, both pre-donation, during donation, and even after donation. I am, however, happy to note that a lot has been done over the past year in terms of blood donation facilitation. I have been a student, and I know it's not easy to improve by double digits. For a long time, we've been hitting 30% target in terms of the annual collection, 500,000 units. And to get to 54% where we are currently is highly commendable. So to the KNBTTS team, I say thank you and keep it up. In addition, I would also like to extend the thank you to the other partners who've worked with the KNBTTS to make this happen. This is the counties, Partners like Amref Health Africa, the United Nations Population Fund, Kenya Red Cross, Kenya Girl Guides Association, the Rotary Club, and of course, Tamusasa. I want to close by saying we're here for the KNBTS. We'll keep supporting. And it's about time also that the whole issue of blood donation begins to be seen as a collective engagement, not just to be left to government, but how do we in the communities as the youth also do our part to ensure that we maintain a regular blood donation culture for the benefit of the patients who are actually our mothers, some are our brothers, and some are our sisters. Thank you very much. Over to you, Madam Christine.
Thank you very much, Mr. Aaron. That was really great. You have really come close to the donors and you've really talked about preventive measures. That's very great. And I'd like to say that our BMIS system that is about to be launched soon, the Blood Management Information System, will be able to enable us to get closer to the donors by giving back those SMSs and telling them what their blood has done. I believe that will really be able to improve the blood management system. Thank you very much for that. Let's go back to Jumapili. Jumapili, are you back on call? Jumapili?
Are you hearing me?
Oh, Jumapili, you're back. You're welcome. Yes, we can hear you. Go ahead.
Yes.
You have 10 minutes. Yes.
Can you hear me now?
Yes, yes. Just go ahead. Thank you.
Yeah, thank you so much. One thing that we appreciate the effort done by KNBTS to ensure that there is adequate and safe blood in the country. First and foremost, one thing that we need to put into consideration is we need to appreciate the informatics. And by saying informatics, it means we need to use our data in our facilities or wherever we are, first to know if, as a county, what is my blood sufficient? Have I reached at the blood sufficient as a county? Is my county, do I have my blood need in my county? Do I know my blood need? Do I know my blood usage? Then the use of the relevant available guidelines is very, very important to know, because sometimes we might practice. We might do some practices that actually they are leading to making our stock or our blood not to be available. Then the issue of TTI screening, very important. We need to analyze that and see how is our data on TTIs levels. Then we also need to analyze our deferrals. What are the causes? What are the reasons for our deferrals? Is it because of anemia? Is it because of non-communicable diseases? Is it because of communicable diseases like malaria? So that now appropriate measures can be done. Then we need also to know our component preparation. Have we reached the level that is required in component preparation? And then also we need to know our personnel. How is our level of personnel? Are they trained? Yeah, are they trained on the machine? Are they trained on blood transfusion? Then we need also to assess the HTC. The HTC, that is the hospital transfusion committees, are they viable? Are they active? Then do we analyze the data of our donors, our regular donors? Do we have our regular donors data? Then the second thing that is very, very important, especially on building a culture, is donor education. We need to educate our donors, that is donor education to the public for voluntary, non-remunerated donors. This should be the message, so that our community realized that if my county is having a population of 900,000, then we are expecting around 10 to 18,000 blood, so that each individual can donate once or twice. So that information must be there to the community. Then the other issue is, where do we get blood? Blood is actually in the community. So how do we put on board the community? Now we develop a community model for blood transfusion, and that is by use of the existing policies that are there. For example, the primary healthcare, where we have the hub, where we have level 1, level 2. So using the CHVs, giving them knowledge on blood, then our community are able to be responsive. They are able to call for blood donation. If we want blood, we just go straight to the community health volunteers, tell them that we need blood. They organize for the blood donation in their areas, and then our officers go and get blood from the community by use of the CHV. But here now is a challenge for all of us. I think we need to come up with a package for the CHVs on blood donation, on blood, so that when they go pass to the community, when they go and discuss to the household, which is their daily activity, they are able to give the right information on blood. Then the other issue that we need to put into place is scaling up blood donation centers. This is very crucial, and this can be done in many ways. The other ways is to ensure that the sub-counties probably take or own this service, and then they make their own programs for blood donation, and the relevant satellite goes and make that blood donation. Then the public-private partnership engagement. This is very, very important, because it will create an avenue for increased blood collection. For example, these private public partnership can be the health facilities, whereby these will act as blood donation centers for our case. And also any other, probably the business in the business world. Then service integration is very, very important, because this is an opportunity that can be applied to ensure that there is blood, there is availability of blood. Because we have seen that blood transfusion is not surviving alone in the healthcare system. It is actually part of the healthcare system. Therefore, any opportunity coming, it is we are able to utilize, because we cannot say that these are HIV patients, these are diabetic patients, or these are, because at long last, these patients might need blood. Therefore, we also need to integrate blood donation into these specific programs. Then we need to practice the accountability. And as I said, regular blood donors, we need to put data into place, which is very, very important. And also the donor education, and also we need to see other avenues. For example, putting on board the borders, very key. Putting on board the minority communities, for example, putting on board probably other community groups that are very specific and unique. This one can also assist. And I know as a country, we have started with the border. We can also go to others, because currently we normally use schools. So borders, we can go to other communities. I think with that, also, we need also to see, for example, in schools, how are we going to motivate our schools? Because it is not an issue of going to school and getting blood and go away. We also need to create value to the schools. For example, a simple appreciation, just doing or teaching these students like Form 3 and Form 4, because in many schools, I understand like in our place, we have negative attitudes towards science and mathematics. So blood donation can be used as a tool to change attitude, and this one really teachers appreciate as a contribution of the department, and therefore our officers are able to go and give health talk on, for example, the blood grouping. So when they do that blood grouping, they do practicals for the students, then the students appreciate because they will not forget this in their exams. And therefore, this one creates a sustainable way of getting blood because these are our donors because they are static points. They are static points, therefore we can really use them. And then also use of health education. These are avenues we can use in getting blood. So thank you so much, and we invite other speakers. Thank you so much.
Thank you, Jumapili, for that presentation. That was great. You tried actually to answer some of the questions. So now we go to the question and answer session. And the first question is by Anonymous. Okay, regulation and monitoring, and specifically rogue privates may be a challenge. Maybe I give that, well, I think you're just going to comment about it, about the rogue private hospitals, number one. I know you are on the regulation. Mutai, kindly allude onto that one, that question. Alex?
Thank you, Christine. The Anonymous, thank you for the question too. Currently, what we have started on is to start setting up the classification of these facilities, and together with the National Blood Transfusion Survey, Transfusion and Tissue Transplant Service, we shall be able to provide guidance on the process of application for those facilities to be registered and the products that they are going to process or manufacture within those facilities. Why we want to do this is so that we can have a standard way of all facilities having a standard way of doing things and giving each facility a license as per the activities that they are going to do. So it's on the pipeline and will soon be on again to let everyone know about this. Thank you very much. I hope I've answered the question.
Thank you very much, Alex. We go to the next question. This is quite a long one. It has come up due to the presentation of Aaron. It's by Penina Dhumbi. Thanks everyone for such a beautiful presentation. It is interesting to hear that most frequent donors are married, 28 to 35. Would that be because they are more in touch with the system and aware of the need, possibly highlighting the need of an expanded communication strategy informed by research? The youth might be donating in high school and then getting lost. I'm sure the BMIS will probably assist with tracking them and keeping them in the system using the very well-articulated customer relationship strategies shared by the DAMU SASA representative. Yes, I think that was just a comment. But we can also allude on the BMIS system. Mr. Chepkok, kindly. Mr. Chepkok, could you talk about what the BMIS system will be able to do?
Yeah, thank you, Christina. I hope I'm audible right now.
Yes,
Am I
you're breaking a
audible,
bit,
Christine?
but you're now audible. You are breaking before, but you're now audible.
When I talked about the thank you. When I talked about the blood management information system, this is a system which is homegrown, which has been built by our own people here in Kenya. And what we want to achieve is, one, is that we have the correct information. That means we are, that is number one. Number two is to track the blood. When I said from vein to vein, that is accountability. We account for any blood which has been donated. Number three is for statistics. We should be able to get the statistics with a touch of a button. Issues of hemovigilance. How many pints have we donated in Kajiado County? What was the usage? How many blood products? The one which is very, very important right now is that this blood management information system is that we shall have donors registering themselves, saying that we want to donate, and they'll be in our bank. When we require them, we just press a button. It's going to tell them, guys, this is the time you can come and donate. After 3 months, it can give you a message. Thank you, you donated last time. The blood was able to save so many lives. You cannot, right now you can come and donate another round. And by doing this, we shall not be talking about 500,000. We shall be talking about 1 million and above. And by doing that, the donor replacement will be something of the past. I hope I've answered the question, Christine.
Thank you, Mr. Chepkok. You've answered the question. I am seeing that our participants have really tried to answer the questions. Is it possible for blood transfusion? So there's another one, another question here by Joseph Otora. Is it possible for blood transfusion centers in Kenya to screen blood samples from the donors before they do the donation in order to take control of wastage? I can give that to Alex. Alex, you can answer that question kindly.
That would be against the regulation, especially the WHO guidelines don't allow for screening before testing. If anyone would want to have a test, let them have a test. And for the donors, we want voluntary non-nominated donors who are, according to the stipulated guidelines on voluntary donation, is willing to donate and going through the processes up to the end where they're going to know where their blood is safe, where they, not their blood, themselves are safe donors or not, through a system that has been established as per the structures thereof. Is that okay, Christine?
Okay, thank you, Alex. There was also another question on by Beatrice Lungai. Are there plans to strengthen and capacity build county referral hospitals to screen blood instead of referring samples that sometimes take long to be screened? I can try to answer that a bit, then I give someone else to add to what I have to say. I will say that as KNBTS, we are really encouraging centralized testing. Somebody mute, somebody is talking. We're encouraging centralized testing by making sure the turnaround time, somebody mentioned, that is at 48 hours, goes even lower to 24 hours. And how we want to do that is by having a high throughput equipment and also increasing personnel. And why we encourage that centralized testing is because of quality. Quality systems are improved when centralized testing is happening. And also we have equipments that are able to be very sensitive and specific. So we do not encourage small kind of testing because, again, the economy of skill. It doesn't really give exactly what is supposed to be given. And as KNBTTS, we are also going towards NAT testing. So you can imagine if we are able to screen all the blood using NAT testing, that will be very, very great, and quality will be improved, because that's our end game: safety and availability and adequate blood. Thank you. So I can also give Susan to elaborate on what I have said. You can maybe add to what I've said about centralized testing. Thank you, Dr. Susan.
Thank you, Christine. You have responded very well, because when you have many facilities, small, big, it becomes very difficult for you to control for quality. But if you have centralized testing, but make sure that the supply chain works efficiently, then that's a better approach. Thank you.
Thank you, Dr. Susan. We can see that we are almost out of time. I would like to give this opportunity to our head KNBTS. Kindly, if you are in the call, kindly say something and maybe talk a bit about what has touched you in the presentation. Thank you very much. Welcome, Dr. Nduku. Dr. Nduku, are you in the call? Thank you. So it looks like Daktari has maybe gone out shortly. So all the questions have been answered. And sorry? And we come to the end of our session with a parting shot for today that says that you can't buy it, you can't buy it, you can't manufacture it, it is in our veins, and let us share. This has been a very productive session and very educative, and we have all gotten a lot from this session. And for Friday, we are expecting another session now on BMIS, the Blood Management Information System. That will be Friday between 10 to 12, accountability and visibility of blood. Yes. So thank you very much, our speakers. Thank you so much for availing yourselves, and the discussants also. We feel very humbled. I want to also thank KNH and Nairobi University. This is a great job for helping us to manage all this. We really thank you and we appreciate you. So we end the session. One can leave at their own pleasure, but I think we can pray. Somebody can pray for us. Jumapili, can you pray for us? We end the session.
Hello?
Yes, pray for us.
Pray?
Pray for us.
Yes, I'm a Muslim, and therefore I'm going to lead the prayers in a Muslim way. So,
thank you, no problem.
Yes, Al-Fatiha, Bismillahir Rahmanir Rahim, Alhamdulillahi Rabbil Alamin, Ar-Rahman Rahim, Maliki Yawmiddin, Iyyaka na'budu, Iyyaka nasta'in, Ihdinas siratal mustaqim, Siratal ladzina an'amta alaihim, ghairil maghdubi alaihim waladdallin. Amen. Thank you so much.
Thank you very much, Jumapili. Thank you. Thank you to the participants. Thank you so much for the ones that have been able to respond to the questions. I know our time has short. Whatever we have not responded, we can you can still continue getting the answers. You can put it through across Friday. Thank you very much for all. We really appreciate and thank you for your time. So goodbye, and you can leave at your own pleasure. Thank you very much.
Thank you, everyone. Thank you, Christine.
Thank you.
Thank you, everyone.
Thank you, everyone.